Familiar faces. So just a quick, we are going to get started in just a moment. We are going to record today's session. We had a few folks who couldn't join us and want to, get this information out to as many people as we can. But I'm Kathy Rogers, Executive Director for Mental Health America. Andrea Towner is a member of our staff, and she'll be monitoring the chat box. So I encourage you to leave any questions or comments in the chat. And at the end, if we have time, we'll just open it up for folks to ask questions. But I'm really excited to have Ashley Moser, who's a Vice President with the Renfrew Center. She is located here in Charlotte, but it looks like you're over several locations for Renfrew. And we're going to be talking about eating disorders. I know there are a lot of myths and misinformation out there around eating disorders, so hopefully we'll be able to dispel some of those and get some important information out to folks who joined us today. So again, thank you for being with us. And we're going to just jump right in. And Ashley, I always like, these continue to be, even though we're kind of transitioning out of the pandemic, they do continue to be challenging times for us. Just want to check in and see how you're doing and how you've navigated the last several months.
Yeah, I love that you start with that. I'm like, wow, it's been a long time since I feel someone's just been like, genuinely, how are you, before you get started into these kinds of conversations. So I appreciate that. I think I'm coping. I think that's probably the best word to probably use to describe. As a human existing in pandemic and post-pandemic times, man, there's been some challenges. And I think the piece that weighs on me probably the heaviest as of right now is the kind of resulting mental health crisis that's kind of happened post-pandemic, current pandemic, wherever we kind of are. It's hard to pinpoint what the best verbiage is for it. But the mental health piece, I think, has just felt really heavy recently. Most of our patients and people that we are serving are struggling in very serious ways. And I think even those people that you know personally, whether they've struggled with mental health issues before in the past or not, are feeling the impact of really surviving a pandemic for the past year plus. So I think the heaviness of the mental health crisis, that those who maybe weren't struggling before are struggling, and those who were struggling before are struggling even more significantly than before, and just access to care and getting enough resources out there. I think it's a real pull on the mental health system, and I feel the heaviness of that, and the real desire to try to help navigate and provide as much resources and support to people, because it's just needed so much now more than ever.
Right. You're so right about the fact that we're all kind of in this space of really struggling every day is a different day. But I write a blog, and I have read an article about languishing, and it was such a great article, because it really is a mental health term that kind of, maybe you're not, struggling with a severe mental illness, but kind of we may be just languishing, which means we're not thriving, which is where we want to be. So so that's so true. I think we're all kind of in this space of whether we're languishing or just really struggling with our mental health. So thank you for sharing that. So let's talk about eating disorders. Could you define what an eating disorder is?
Yeah, absolutely. So eating disorders are really complex mental health conditions. So there is definitely a psychological component to eating disorders, but there's also a nutritional and a medical component to eating disorders, which makes them a psychiatric disorder that is really complex and has kind of that level of severity that puts them in a position of potentially having some pretty serious complications. One of the myths that we oftentimes struggle with is that patients maybe don't follow through and reach out for care, or maybe treat their illness with the appropriate level of care, because they sometimes feel like, well, it's just my relationship with food, or it's just my relationship with my body, or it's just my relationship with exercise. It doesn't feel as pressing, as important as maybe some other conditions. And I think, I'm really happy to be here today to be able to talk about some of the myths, because I think a huge myth is that eating disorders are sort of these surface level issues that can kind of be put off to after work, on summer vacation, after more important things are dealt with. And they are actually a serious mental health condition that can have a high mortality rate. So whether it's related to medical complications or, suicidal ideation, those are things that kind of walk hand in hand with eating disorders. So they can be incredibly serious, even though I think one of the myths can be that it's one of those disorders that maybe isn't as pressing.
Right. So what are some of the common myths around eating disorders? You mentioned it definitely isn't just about food or physical, or it seems so complex.
Yeah, absolutely. I think one of the biggest myths that I oftentimes hear is that the belief that we can tell if someone has an eating disorder just by looking at them. So there's the thought process that if someone's really struggling, it will show up in their physical appearance, that their weight will be dramatically impacted by their eating disorder. And something that I've really come to find, and I know the field is very open about, is that weight is really not an indicator of health. So I've seen people who have been in lower body weights that have actually been in a healthy place. I've seen people who've been in high body weights who have been in a healthy place. And I've seen people who have really been at what is called, quote unquote, a normal or average body size that have been severely entrenched in their eating disorder and need as much support. So a big myth is that you can tell if someone's struggling by their weight or their physical appearance. And what we continue to see time and time again is that body shape and size is really not correlated with someone's overall health. So that's a huge myth that I like to put out there, because eating disorders hide in plain sight. They oftentimes are not correlated with someone's weight. So you really want to be asking questions and connecting with people and finding out more about how they're doing, versus assuming that if they look okay, they must be okay. Or if they're not looking okay, they must not be okay.
Right. My daughter played college soccer, and one of her teammates, who just was an amazing soccer player and athlete, but she struggled with an eating disorder. So it definitely, you cannot tell by looking. So what are some other misconceptions or myths? And please, if you guys have any questions, share in the chat box.
Yeah, absolutely. I know another big one is that eating disorders only affect a certain subtype of the population. So I know sometimes there's the belief that it really only impacts women who are young, who are affluent, who are thin. And while that may be kind of the stereotypical picture of eating disorder patients, or maybe more likely to be somebody who is actually able to access treatment for an eating disorders actually do not discriminate. So it is something that affects people across race, socioeconomic class, gender, orientation. It's really not something that you're only susceptible to if you fall into these certain demographics. It's really something that does not discriminate and can impact people across the population. There's definitely differences in terms of access to care, who has the insurance, who has the out-of-pocket ability to pay for resources. So that, I think, sometimes skews who we think is struggling, because those are the people who have access to the resources oftentimes. However, it really does impact people across all demographics. And so because of that, it's important to kind of expand our view of who could potentially be struggling. So again, we can't tell by looking at someone if they could be necessarily impacted by an eating disorder.
Wow, that's a great point that you make, that access to care. So those that are able to access treatment and can skew our perception of who has a particular mental health diagnosis. So that's a great point. I also read that we often think that it's our teen years when these begin to manifest themselves. Can you speak to that myth?
Yeah, absolutely. Yes, you're right. Age is definitely one of those myths. Oftentimes, some people do struggle and develop an eating disorder in their adolescence or young adulthood, but there's very often times that, people in older demographics struggle with an eating disorder for the first time. And that could be influenced by a range of issues. But what some of the common issues that we do end up seeing are that there's a lot of life transitions that happen as we age. And I think some of those transitions, whether it's marriage, divorce, children, no children, entering the workforce, leaving the workforce, menopause, aging, things along those lines can definitely influence and result in the development of an eating disorder. And if we really think about eating disorders not just being about kind of that weight, food, relationship with body, and being more of a response to emotional distress, it makes sense that the older we get, don't tell the young ones, life doesn't get a whole lot easier. It tends to get a little bit harder, but we may need to sometimes, we need to develop ways to cope and manage through. And oftentimes the use of eating disorder behaviors can really help us manage difficult life circumstances. So it's very common that as people progress in life, their risk factors for eating disorder still are very much prevalent, and that they can struggle for the first time or have a relapse or a reoccurrence of something that they struggled with in their youth and have that return as they get a little bit older.
So we'll take a pause, Ashley, but I had a follow-up on that. But we do have a few questions. I know Maria's got several questions. Andrea, do you want to share those with Ashley?
Yes, yes. The first two questions come from Cindy asking, what are the DSM criteria for diagnosis, first of all?
So there are three sort of primary prevalent eating disorders that are in the DSM. So we have anorexia nervosa, we have bulimia nervosa, and we also have binge eating disorder. There's also avoidant restrictive intake disorder as well. And those are the diagnoses and the actual eating disorder classifications that show up in the DSM. However, there's a wide range of disordered eating. And so there's kind of a continuum of people struggling from kind of overall wellness to kind of meeting criteria. So depending on which diagnosis we're looking at, criteria potentially revolves around the severity, frequency, and duration of engagement in a certain symptom. So if we're looking at anorexia nervosa, this would be specifically surrounding potentially restriction. So restriction is when we deprive ourselves of food or the opportunity to eat when we do feel those biological hunger cues. So it's eating less than what your body is actually craving for, and restricting, and that can be restriction in terms of volume of food in general. It could be restriction in terms of fluid. It could be restriction in terms of foods you enjoy. I only eat things that are healthy versus things I enjoy. And that restriction is really kind of the characteristic criteria. But then, of course, the duration, severity, and frequency of the restriction is kind of what makes it a DSM criteria. Bulimia nervosa tends to fall, the criteria focuses a little bit more on the engagement in binging and purging. So binging is kind of eating a larger quantity than what you would typically eat in a shorter amount of time and a faster pace than what would be kind of a normal average meal. And in response to that feeling of being out of control almost with the food, that person then engages in some sort of purging behavior that allows the relief or the compensation for that increase in intake. So that can be done via self-induced vomiting, that can be done using diuretics, that can be done via exercise. And so those are sort of the characteristics. And again, severity, frequency, and duration all play a factor, but those are the two primary behaviors that we see with bulimia. And then binge eating is similar to bulimia in the sense that the binging is absolutely there. So eating large quantities of food quicker than usual in a shorter period of time, but there is no compensatory behavior afterwards. So there's no engagement in any sort of attempt to relieve yourself of the discomfort after eating those foods. Those patients are actually engaging in restriction a lot of the time. So when you have a large quantity, you then sometimes fall into the pattern of not eating and not nourishing, which ends up then setting you up to binge yet again. So you get stuck in kind of this restrict binge cycle.
Mm-hmm. Wow, thank you.
Yes.
A follow-up question from Cindy was, what are some emotional or psychological seeds that may have been planted? I'm sure it's variable, but some common things that you can share?
That contribute to the eating disorder development? Yes. So Depression and anxiety are common comorbid issues that travel along with eating disorders. It's very, very rare that someone that we're treating is just showing up with meeting criteria for an eating disorder. It's very, very common that you're also struggling potentially with anxiety, with depression. Oftentimes there can be a trauma history. Sometimes yes, sometimes no, it's not a requirement. But that is something that can sometimes be a part of someone's history that can fuel a lot of emotional distress, which then creates the reliance on the use of the relationship with food to manage those emotions. OCD is something that comes along quite often with eating disorders as well. There's a real obsessive and compulsive component that can happen with focusing on eating disorders in terms of, what's coming in, what's coming out. If I do this, then I do that, lots of food rules, etc. So those are the most common psychological and emotional themes that we see. And so we do a lot of work that focuses on some of like the CBT aspects, typical treatment that you would see for mood disorders as well, but definitely focusing in on some of the trauma themes that may have been impacting, some of the earlier, that may have, preceded the emotional disorder and then the use of the eating disorder behaviors.
Thank you.
Yeah.
Do you want to take a couple more questions, Ashley?
Absolutely.
Yes, thank you, Shannon, Maria, for sharing that your 13-year-old son has struggled. Maria asks, what can we do to have better interaction with food?
Boy, that's a big question. I think working towards a more neutral relationship with food can be very, very helpful. I know it's something that's pretty counterculture. There's a lot of eat this, not that, this is good, this is bad. And those are a lot of messages that we're receiving in society when it comes to food. So what I'm asking is a bit counterculture, but it's really helpful. I think working towards a more neutral relationship with food that typically involves focusing in on, what aspects of my food are nourishing my body and focusing on as food as fuel, and really taking the emotion and taking the labeling of good versus bad out of the equation. So focusing in on wanting to make sure that I'm meeting my, let's say, a meal plan that was maybe prescribed by a dietitian, focusing in on making sure you have the right number of starches, proteins, fruits, vegetables, fats, all of those pieces. And when you're focusing in on making sure that your meals are balanced and have variety, it can then take away some of the polarizing feelings about whether this was good or bad. So I think working towards food neutrality can be a really important step. And what I have described can take a very long time to work towards. It's not as easy as snapping your fingers and changing that relationship, because a lot of our relationships with food have been fueled by a lot of interesting components over our lives. If we grew up, the messages we received from our families growing up around food carry with us. The messages we received in gym class about the food pyramid and health class. I mean, there's a lot of places that we've gotten this information. So we can't just snap our fingers and go from these kind of emotionally fueled relationships to neutral relationships, but that really is the overall goal. So that way food can be fuel and emotions can be felt around those foods, but they don't have to be so intertwined.
That's a great answer. I think sometimes we don't early enough teach kids why we need certain foods, that it is to nourish your body, it's to give you energy and strength, and rather than just here's your lunch, here's your breakfast.
Right.
We don't have
a lot
those
of clean plate club.
And that
Yeah,
we try to deprive ourselves from some of those things that maybe are bad, but in moderation, just so you feel that satisfaction.
Yes, and I think that's a huge component of the eating process that I think, especially over the years with a lot of the diet culture messages we've received, that we've removed ourselves from allowing ourselves to enjoy what we're eating and feeling satisfied and satiated by food. And that's a real big component of the eating process. So to allow yourself to have those experiences with food again can be really freeing and bring the enjoyment back to eating versus it feeling like such a chore that's so emotionally just laden.
Right. We'll get to some of the other questions in a minute, but we were talking about the misconception that an eating disorder can start as a teen. Are are we seeing earlier, like younger children begin to have an unhealthy view of food and their body and things like that?
Unfortunately, yes. I do think that that is something that unfortunately is starting to skew younger and younger. There's never one pinpointable cause to the development of an eating disorder, but you know, children are sponges, right? They're soaking up their environments and they're very much
Mhm.
aware of the messages that they're receiving about food in their bodies. So I think they're pretty perceptive. And I think, you know, the messages that they're receiving, whether it's via TV commercials, whether it's, you know, now this, you know, really impactful, you know, social media platforms that children are now exposed to, which, you know, we weren't exposed to previously. And then I think just watching family members interact with their bodies and food, I think that also has an impact. And again, not necessarily a one pinpointable cause. Moms don't cause eating disorders. Dads don't cause eating disorders. Social media doesn't cause eating disorders, but a combination of being in an environment that speaks those messages and reinforces those over time does make you more predisposed to development of an eating disorder, if that makes sense. Because I always steer away, especially being a parent myself, from, you know, reiterating that message that eating disorders are caused by family issues, and that's
Right, right.
not a correlation that we ever like to make, because there's so many elements that go into it.
It has been refreshing to see more ads with different body types showing and celebrating, different body types and not just that ideal of a model or, so that's been good to see that. But I'm sure that as younger people are on social media more and we will see and eating disorders begin to manifest themselves at an earlier age. What are some other myths that maybe we haven't touched on?
Yeah, I think one that's I've been experiencing a little bit more in this kind of post-ish pandemic timeframe. I think a lot of people have believed that their eating disorder was worsened by the pandemic, and that could be the case in a lot of circumstances. You know, isolation is something that really adds fuel to an eating disorder or fire. Being isolated, being disconnected from others really puts you at risk. And so we have seen an increase in eating disorders, because of the isolation that's been put out there from the pandemic. What we're struggling with from a treatment perspective at this point, we have a lot of people believing that, well, if we just go do the pre-pandemic things, our eating disorder will then go away. So if I just go on that vacation I had to cancel, if I just go back to in-person school, if I just resume my life as normal, the eating disorder will then go away as well. And I think what we're finding is that logically, I get it, right? I wasn't able to do these things. I do these things, I'll feel better. But there's still that professional help that potentially is needed, that it's not as quick of a fix as I'll just go back to doing what I was doing before and I'll feel better, that there is still that need for professional intervention. And so I had an opportunity to sneak that in today and wanted to talk about that because I do see that as being a bit of a barrier to care. And my concern, obviously, seeing the impact of the mental health crisis, I worry that it will continue if we're continuing to think that just resuming life is the answer to some pretty deep-seated and potentially dangerous mental health conditions.
Right. That's a great point. So do we have a few more questions? No? Okay.
Haven't seen any others,
Okay.
but please add them if you'd like to, or unmute if you'd like to in our last couple minutes.
So Ashley, if an individual is concerned that they have an eating disorder, or if you see maybe you're concerned about a loved one, what steps should we take? Often navigating the mental health system is difficult, and with an eating disorder, you've got we know physical and mental health are so aligned, but it's definitely clear to see in this case. So what should someone do? What should be their first steps?
Yeah, I think something that I've heard over the years, I think a lot of people who are concerned about a loved one are very worried that if I bring it up and or I say the wrong thing, I could make it worse. And
Right.
so they then hold back, right? And what I've heard people who struggle with an eating disorder say over time is that I felt invisible because I was very obviously struggling and no one said anything. And so it's sort of this situation where the fear of making it worse and the kind of screaming for help, but in a behavioral sense, miss each other. And so sometimes these disorders go on longer than they potentially needed to, because there's a lot of fear around how do I approach someone?
Mm-hmm.
And I think what we really encourage is to have the conversation. It's going to be uncomfortable, and that can be okay. But I think approaching it from the perspective of, I care about you, I'm worried, and here are some of the things that I'm noticing. And you may not convince this person to pick up the phone and call their primary care doctor. You may not convince this person to pick up the phone and call us, but you've extended the outreach that says, I see you, and I care about you, and I'm worried about you. And that, having that initial foundation laid, will open up the ability to have future conversations. So what I often tell, family members and loved ones is to really be patient, but persistent. So just because you said it once and it didn't result in them picking up the phone doesn't mean the conversation's a one and done. It's definitely something that needs to happen over time. And oftentimes, if you're kind and compassionate and persistent, that can really help someone get the support that they need, because it is a disorder that requires professional intervention versus it being something that's kind of like a fad, something they'll grow out of, they'll snap out of, or they'll stop once they've lost a certain number of pounds. You do really want to continue to encourage linkage with a professional, and a primary care doctor can sometimes feel like a great place to start. They know of the resources in the community. You may have had an established relationship. Or if you really want to make that initial step to say, I need to talk to somebody who knows eating disorders because I need someone to really understand this, calling, for getting an appointment scheduled to have an assessment to talk through what could potentially be a best treatment option for you is there as well. So I think patience, persistence, and then the acknowledgement that this isn't something we can just do as a family. We need the professional support, using the resources that you already have, like a primary care physician, to get that process started, or being willing to get on the old Google search and find a treatment facility and doing some outreach, because there's 24-hour chats, there's email linkages, there's lots and lots of ways to get connected to get that initial process started.
We do have a provider directory on our website, which people looking for help can search by diagnosis. I'm sure Renfrew is on there. So if you search by eating disorders, the various facilities or clinicians who deal with that will come up. You can also search it by insurance and by zip code if you're looking for a place that's close to where you are. I know Maria had a question asking if the school systems ever talk about eating disorders. I'm not sure. Do you know, Ashley?
Probably not as much as they should.
Right.
I think there may be some basic, education and awareness. I do know something that we do. We try to do as many presentations for athletic departments, gym teachers, school counselors, just to increase their ability to be aware of those signs and symptoms. But I think our hope, as with any mental health condition, is that the more we're putting it out there that it's okay to talk about it, that we reduce the stigma, so it can be a general conversation that's happening in elementary school, that's happening in middle school, so that we're creating the openness and the ability for people to ask for help and to just have that awareness, because we know awareness does not result in then falling into the disorder as much as it just allows the space to then ask for and receive the help that you need.
Exactly. So we're at 12:30. Does anybody have any last questions for Ashley before we finish up? Ashley, want to tell us real quickly before we finish up about Renfrew?
Yeah, absolutely. So we have 19 locations all over the country. 2 of them are residential facilities. One's in Pennsylvania and one's in Florida. It's really nice because you can go north in the summer and south in the winter, which has worked out nicely. But we, right here in Charlotte, got Fairview Road over my shoulder. So we're right here in South Park. We offer a day treatment and intensive outpatient option. So there are programs in which you can come to us. We support you during the day or in the evening, and then you reside in your home. We are currently operating virtually, but we are in the preparatory of return to in-person services, knowing that that is a need throughout the community that we are wanting to step forth and meet. But we want to make sure, 'cause just like we said, it's a pretty complex illness and one that has a medical component. We want to make sure when we open our doors, we know that we're doing it safely. So I'm feeling more and more confident that we'll be able to do that in the near future. But in the meantime, we do have virtual services available, which is kind of nice to be able to wear your sweats and your fuzzy socks and be able to do treatment from home too. So there's a component to that that's nice.
Yeah, we're all loving that. So,
Yes.
well, Ashley, I thank you so much for being with us today. This has been so informative for me, and I'm sure those who joined us as well. And hopefully you guys can be back in person. Hopefully we can all soon be back in person doing what we love to do. But again, I thank you all. I know Andrea will be sending out an email. We did record today's session. She'll have an evaluation and usually has a lot of great resources for folks who want to learn more beyond today's session. So Ashley, thank you again for being with us, and thank you all, and look for our next event. I don't know what that's going to be yet, but but we will certainly let you know when we have the next Mental Health Matters scheduled. Thank you all for joining us. Bye, everybody.
Thank you. It was great. Good information. Thank you so much.
Great. Thank you, Barbara.
Thank you.
Thanks, Cindy. It's good to see you. Bye, everybody.
Thank you.